So I'm going to talk about a relatively new biomarker in practice already in early stage colorectal cancer. So I'm going to introduce obviously the field and go through what the issues are, introduce the biomarker, and then show you how it can be potentially useful. So first of all, a little bit of basic background. Obviously, we know that colorectal cancer is a major public health issue, third most common cancer worldwide, millions of cases each year. 5-year survival is still 65%. And as we know, when the disease spreads beyond the primary organ, primary colon, the 5-year survival rate is very poor. Many present late. However, when patients do present early, standard treatment is surgery plus or minus chemotherapy, depending on stage, and that's the standard treatment at the moment. So the main issue really with early bowel cancer is how do we prevent the cancer from coming back? As the stage increases, as we well know, the chance of the relapse is higher. And as you can see from this 5-year survival rate, early stage cancers have a very high cure rate, 90%, going on to stage 3 at 71%, and obviously I mentioned before metastatic disease at 14%. So we need effective ways to risk stratify patients, and presently we use a TNM stratification. And as we know, the TNM stands for tumor nodal lymph node involvement and metastasis. The data is quite clear that, for example, 2 stage 3 patients will have a different risk of relapse, but get the same treatment in the adjuvant setting, that is chemotherapy after surgery. So this stratification isn't necessarily a great way of assessing patients, and clearly needs to be optimized to prevent patients from being overtreated or even undertreated. We know the people who treat this type of cancer, and I'm one of them, that the drugs used in the adjuvant setting to prevent the cancer or reduce the risk of the cancer coming back are very toxic. Some of the toxicities can be lifelong. The drugs have side effects which can make people become seriously ill, and we know that we are undertreating and overtreating, perhaps maybe overtreating mostly. Okay, so to get a better understanding of trying to assess risk of recurrence, we need to have a better system, as I mentioned. And over the last few years, many other things have been looked at, and there's some mentioned here from tumor mutation status as a better understanding of actually the disease biology at the kind of DNA level, biology such as tumor cell origin, and these have been shown to have moderate prediction accuracy and actually limited clinical effectiveness or usefulness to determine the risk of relapse and prognosis. So again, a greater understanding is needed. And that genius Paul Ehrlich in 1900, over 100 years ago, postulated that the immune system, which was rudimentarily understood at the time, could protect or get rid of cancers. He didn't really have any evidence for that, but this is obviously a mark of the man, how clever he was, that he postulated that something in the body could try and get rid of cancer. And later, only sort of maybe 50 years after, experiments in mice and later in humans showed that some cancers could spontaneously regress. And these happened in patients. Not much understanding was found about why this happened in certain patients, but postulations again were the immune response in certain patients. And later evidence was shown that around a pathological specimen of cancer, that the amount of immune activation around the tumor was linked to survival. And using this information, this in situ kind of immune cell infiltrate, it was postulated that the immune system in certain patients could try and get rid of the cancer, and that response was linked to survival. So again, this, with more understanding of the immune system, as time's gone on, there's been sort of many forward movements and backward movements, that the cancer immunity cycle was postulated, where cancer cell antigens are presented to the immune system, and in some patients, there's a deep infiltration of T cells, the body's immune response, into tumors. And this presence of the T cells has been utilized in many cancers with the cancer immunotherapy revolution, where drugs which help stimulate those cells which are around the tumor to be activated and get rid of the cancer. So the latest discoveries on this immune and microenvironment have really changed our cancer diagnosis and treatment approach, at least in the metastatic setting. So more important than the clinical pathological features, that's the size of the tumor, lymph node involvement, other risk factors such as, is the cancer in the local blood vessels, or is the cancer in the local lymph vessels? It's pretty clear from all the evidence that tumor progression, i.e. the tumor getting worse and invading and spreading, is determined on the body's pre-existing immune response. And this is very clearly linked to survival and the fate of the patient. So as I mentioned before, understanding of the tumor biology was looked into to see if that could affect or determine the tumor recurrence rate. But from the data now, it's quite clear that the immune response has the majority of, gives us the majority of the risk of the chance of the cancer coming back. So this is not even tumor intrinsic, this is extrinsic to the tumor and the body's response. So with this information, the WHO has now said that the gold standard of assessing the diagnosis criteria is an immune response as well as a TNM to complement the staging. Okay. So just before we go on to the next section, I want to go on to what defines a good biomarker, because a biomarker should be clinically validated, i.e. lots of large studies to show that this biomarker is actually useful and the results are repeatable elsewhere in different settings. It's got to be accurate, it's got to be better than what we've got, i.e. TNM. Repeatable, you repeat the same test, you get the same result. And in different settings, from rural to urban settings, you get the same result. And also, obviously applicable, are they actually useful in clinical practice, and do they actually change what you do? So what is the difference between a prognostic and prognostic diagnostic test? And this is quite important for patients to understand that. So the patient's journey, you get diagnosed with your cancer and you have treatment, and you hopefully the cancer doesn't come back. But ways to work out the chance of relapse are certain biomarkers, but predictive biomarkers really are useful to tell us if the treatment that you're going to go on is actually, you're actually going to respond to the treatment. And many examples of that, for example, BRAF mutations in certain cancer types can determine whether you respond to BRAF inhibitors. But this test is a prognostic marker, this Immunoscore, which I will talk about. This determines, tell us the risk of the recurrence, which isn't necessarily the same thing. There are biomarkers which determine both, but the immune response in this situation is more of a prognostic marker. Okay. So, as I mentioned, the immune response is now a very important marker of risk of relapse, and this is formally assessed by Immunoscore, which is pathologists use a digital imaging to determine the immune response within the tumor and at the tumor margin. So we're looking for the T cell infiltration, CD3 and CD8 cells. So having a low Immunoscore means you've got a high risk of relapse, and that means you don't have many T cells around the tumor or in the tumor. And a high Immunoscore is the other way around. You have a lot of lymphocytes infiltrating the tumor and the margins, which means your risk of relapse is lower, as mentioned previously from all the previous data. So this biomarker has been validated in a large international study looking at over 1,000 patients in 13 countries, and the results have been similar throughout and published in the Lancet. So this was again looking at, as I said, CD8 and CD3 cells around the margins of the tumor and within the tumor itself. And basically it's a marker of pre-existing immunity from the cancer to the immune system. So the key characteristics are filled, it's clinically validated, large-scale retrospective studies in many centers around the world. It's accurate, pretty much the same results were obtained in every center, and repeatable and stable. I mean, the pathology samples would just use simple IHC to stain these CD3 and CD8 cells, which means it can be reproducible in all environments and applicable. The results showed that the higher the lower the score, the more, sorry, let's go back. Sorry, let me just go back. So the results showed that the higher the risk is with a low Immunoscore, low infiltration, and the lower risk of the cancer coming back, the higher infiltration, sorry. So now, when you see your doctor and you've got stage 2 or 3 bowel cancer, he or she can determine more accurately than previous your risk of relapse. We will not stop using the TNM staging, but with Immunoscore, you're actually getting 47% increase in information to determine your risk of the cancer coming back. And it gives the highest relative contribution to the survival, including the TNM classification. Okay, so basically now we can really tailor our treatment, our chemotherapy treatment, to patients and not have a one-size-fits-all treatment in this setting. So say, for example, you are a stage 2 patient. These patients do not have lymph node involvement. However, they can have relatively large primary tumors, and they are high and low risk stage 2 patients. Definitions of high risk stage 2 patients include patients who present in an emergency setting, who have lymphovascular invasion, and have large tumors. These patients are sometimes offered adjuvant chemotherapy with that information not being that actually useful to determine the risk. And with Immunoscore, you can see here in this patient who has a high clinical risk, who probably has a large tumor or lymphovascular invasion, he has a high Immunoscore, meaning the patient has a low clinical risk of relapse. And in this patient, you may have given chemotherapy in the past, but now with this Immunoscore, you can help risk stratify further. In the stage 3 patient, this is slightly redundant, this information, because the recent survival data idea collaboration comparing 3 versus 6 months of adjuvant chemotherapy in stage 3 patients. There was data initially suggesting that in high-risk stage 3 patients, that 6 months worth of chemotherapy and all the toxicities that come along with that have a lower, gain greater benefit from 6 months worth of chemotherapy than 3. So in this situation, in the past, we could use Immunoscore to see if patients really do need 6 months worth of chemotherapy and all the associated toxicities that go with that. So we can see here, we've got a stage 3 patient who has a high Immunoscore here, and there's a low chance of relapse compared to someone who has a low Immunoscore. So maybe with the patient with the low Immunoscore here, we could offer 6 months worth of chemotherapy as opposed to 3 months. But as I mentioned, that this data may be slightly redundant with the recent survival data suggesting that 3 months may fit all patients in this setting. Okay, so with this, what we call immunomics precision medicine, the paradigm of how these patients are risk assessed has changed. And also, so basically we can assess your Immunoscore to better know your cancer's actual biology and risk of relapse. We can determine whether the patients need chemotherapy and avoid the potentially life-threatening or life-changing toxicities. We can personalize your treatment. For example, I mentioned there that some patients you may consider giving 6 months worth of chemotherapy to. If they have a high Immunoscore, you may consider giving them 3 months. You can maximize your chances of survival. I showed you there with stage 2 patients you may not want to give chemotherapy to. If they have a low Immunoscore, you may consider then giving them chemotherapy, which may hopefully increase their chances of reducing relapse and then hopefully survival. And with the patients, you can discuss the patient's Immunoscore to help make best treatment decisions for your patients.